Good afternoon. I am Ryan Kazami, and practicing oral surgeon here in Bethesda, Maryland. Thank you so much for joining us for today's live narrowcast. The narrowcast is our version of the webinar, and I appreciate clinicians who have joined us from around the globe. Today, I would like to sort of spend the next 30 minutes talking about the management of extraction sites with sinus perforation. As we go through the presentation, if you happen to have any questions, feel free to send them to our email, info@facialartdentalforum.com, and I will take a few minutes at the end to answer those questions, and we will spend some time doing that. So let's talk about this topic. The extraction of teeth with perforation of sinus is part of a larger presentation that I cover in the posterior maxilla, but we're going to kind of focus only on this one particular topic. And what I want to do is talk about our recommended and proper diagnostic imaging, as well as a traumatic extraction technique, and also really focus more on how to predict post-extraction sinus perforation, and also what we do about it and how we manage it if they're observed at the time. And we'll also talk about the site graft and its efficacy in ridge preservation in these situations. So let's kind of go over a couple of cases here, just to kind of demonstrate some of the actual presentations of this type of situation. So first, let's look at this patient who came and was seen by dentists and for evaluation of tooth number 3. And was planned for an extraction. And on the periapical x-ray at the time when she presented, basically we can appreciate the location of the sinus floor and how it silhouettes or follows the anatomy of the root. There seems to be a larger area of radiolucency, which very difficult to pick out in terms of its extension. And also the panoramic x-ray is relatively difficult to interpret the degree of this radiolucency. So patient subsequently had the tooth extracted, and about a month later post-extraction, she presented with infection, pain, and that is the time that I first saw her. And right away we took a CT scan, and we can basically see what has occurred. She developed an opening, an oral antral fistula, with a large area of sinus obliteration. There was infection, some purulence coming from the site, and that's how she presented to us. And so this is very typical symptoms and signs and symptoms for an oral antral fistula, where we see pain, purulence, indicative of infection. Also, there is no air seal, so there is basically between the sinus and the mouth there is no air seal, evidence of sinusitis, and also a complete antral communication. And these type of conditions are typically require a management which consists of managing the infection, some type of a soft tissue closure, and also bone graft in order to try to manage the oral antral fistula. Here's another patient who basically had tooth number 15 with an appearing radiolucency on the root, and the patient was actually scheduled to have an extraction done at a dental office. And the only reason that she sort of postponed was because she asked for IV sedation. So that's when the patient was sent to me, and upon her presentation, this is the x-ray that she brought. Since I couldn't really visualize the apical aspect, we took another periapical x-ray, and we can kind of appreciate that there is still radiolucency, but very difficult to appreciate the extent of it. Just how far does it go? and not being able to appreciate or at least diagnose it on the routine periapical x-ray, we proceeded to take a cone beam CT scan, and now we can really understand the extent of the radiolucency, the bony defect, and also the observed perforation into the sinus. There's also seems to be a radiopacity in the sinus, which may be indicative of sinusitis and very much possibly related to this tooth. So now we were able to really understand the circumstances of this lesion. Here's another patient with a periapical X-ray planned for extraction of tooth number 3. And in this case, this is from several years ago. A patient that I treated took a second periapical X-ray, and I can kind of appreciate the extent of the periapical area and also the periapical cement, very much close to the sinus. In this case, I did not take a CT scan. I had proceeded with the extraction, and perforation was noted after the tooth was removed. Obviously, at that point, we proceeded with the site graft in order to manage it, and the patient ultimately healed well and did not have any complications. But this was managed or observed and managed after the extraction. And we look at another patient, again, that also has tooth number 14 planned for extraction, and we can kind of see the periapical X-ray with the what we think is the sinus floor and outline, and it's really difficult to know exactly the dimension. In fact, when we do a CT scan, now we can kind of appreciate the extreme nature of the sinus pneumatization in the between the roots and also the apical region, and now we have a much better image and plan to be able to do the extraction in a more predicted fashion. And in fact, here is the patient 4 months after the tooth was extracted and when the site was grafted, and we have a closure. There was no oral antral fistula, but we can see that there is very minimal bone. Of course, for implant therapy would have to be enhanced. So I think I show these cases so that I can kind of really make a major point. And the major point is that when we look at all these various cases, and we have a routine conventional X-ray, of course, that we start with. So if we see on conventional X-rays a periapical lesion, some sort of a defect that surrounds the roots, perhaps the sinus floor that appears to follow the root anatomy, and also maybe the inability to see the periapical area, and also if the patient has symptoms such as sinus disease, a draining fistula, things that we cannot quite appreciate and see on the X-ray, then it's very much important that we follow these steps. And the steps are basically to obtain a CBCT. I think the cone beam CT scan is a must. It's a requirement for proper diagnosis and planning. And without it, we will be surprised, and the patient will be surprised by what we may find intraoperatively. Then this will allow us to provide the patient with proper education, an informed consent process. We have the opportunity to plan ahead for the sinus communication that most likely will occur. And also it'll allow us the ability to perhaps use a more atraumatic extraction technique, knowing that the periapical aspect is very close to the sinus. We can also plan for the site bone grafting, soft tissue management, and also making sure that we give the proper postoperative instructions. So having the proper diagnostics will allow us to really do all this ahead of time and be able to have a much more accurate plan in place. Now, first, let's talk about the atraumatic extraction and site graft. And obviously, the extraction of any tooth in the atraumatic fashion is important to preserve bone and soft tissue. But in this case, if they're close to the sinus floor, then we would want to minimize any type of excessive bone loss and minimize the perforation. So atraumatic extraction with sectioning of the roots, removing each root separately, and then going ahead with site preservation grafting, which has the benefits of preservation, augmentation, and also maybe minimize the sinus pneumatization in the process. Now, one of the questions that we always ask and have looked into is, what is the efficacy of the ridge preservation grafting on sinus pneumatization? And this was a paper that was done by John William Thousand in June 2015, and had really looked at the mean volumetric changes of the maxillary sinus in non-grafted maxillary posterior teeth. And what basically was observed is that the ridge preservation grafting might reduce the sinus pneumatization after tooth extraction. And I think the critical point is that the word might. There is no clear sort of a proof that the sinus will not pneumatize after site grafting. So the conclusion was that such changes can be mitigated, but not entirely eliminated by ridge preservation. And I'll show you how that is the case in a couple of cases. So let's now focus on the extraction and management of the sinus perforation. Here's a patient who, again, presented with a tooth number 2, the upper molar, that was planned for extraction due to a endodontic complication and fracture. And we see that, again, on the periapical x-ray, there is a very common silhouette of the sinus floor following the root anatomy. And this is, again, shows the anatomy of the sinus. So when we go to take a CBCT, which, as we talked about, I think it's a requirement for proper diagnosis and planning, now we can kind of really appreciate the position of the roots and how close they are to the sinus cavity, and most likely maybe even anticipate that the sinus perforation is going to happen. It's difficult to know if there is some bone, maybe a 0.5 millimeter or a millimeter of bone present, and perhaps the cone beam CT scan is limited in showing us when the bone is extremely thin. But at least we will have some assumptions that the sinus perforation may occur, and so we can have it in our mind. And this is highly important during a patient consultation, when first we advise CBCT as an absolute need for diagnosis, and really informing the patient of possible, maybe even probable perforation and such symptoms that may occur if it's not addressed. What are the symptoms that they may experience? This hole between the mouth and the sinus, maybe fluid drainage from the nose, sinus infection, air leak, and these are all the possibilities that the patient needs to know about. And then we can also review the treatment options, that if a sinus perforation should occur, how we would go ahead and manage it at the time to make sure that we avoid such complications. And of course, have the patient to provide us with an informed consent and total knowledge and alignment with what we're trying to do. So let's go through this patient. So this is the same patient, the x-rays that we just showed. So the tooth was extracted atraumatically, and right away we can appreciate that there is communication at the periapical lesion with the sinus. In fact, all 3 roots, once removed, show that there was a disruption of the sinus floor and also the sinus membrane. So this is clear communication with the sinus. So the first question is, why would we graft it? Now, grafting, as we talked about in this case, would provide us with some bone preservation features, also really addressing the immediate oral antral communication, and hopefully minimize the chance for persistent oral antral opening or fistula, which very much can happen with larger perforations. So for this, I use a 3-layer site graft technique. The first layer is placement of a resorbable membrane or a collagen membrane at the sinus level, where basically provides us a closure or a stop at the apical aspect of the extraction site. The next is placement of the bone graft itself using particulate bone and packed into the area, and to complete it by putting a third layer, which is another resorbable membrane or a collagen membrane at the gingival level. And once this is done, we'll go ahead and do some stabilizing cross sutures to essentially hold the three-layer graft in place. And this is allowed to heal and mature over a 4-month period before proceeding with any implant replacement. Now the question is, with a site graft, as we did, is whether or not is efficacious. Does it work in terms of crestal bone preservation? So if we look at the same case about 4 months later, we can see that we achieved one of the objectives was to certainly make sure that the sinus perforation is not persisted. But we see that the amount of bone that resulted, which is about 2.5 millimeters 4 months later, certainly did not provide us with any predictable crestal bone preservation. And if we kind of look at another case in a very similar fashion, the sinus floor being somewhere in the mid-crestal region from the apical coronal direction, and then the extraction was done, the site grafting was performed, and then 4 months later we come back and we have about 4 millimeters of bone, very much the same type of pattern. So I think one of the observations that I have made, having treated a number of cases with such anatomical presentation, is really the questionable effectiveness of the site graft in preserving the height of the bone when we have this type of scalloping sinus floor biotype. So I think that we have to be probably not as hopeful that when we have a case like these, that once we do the site graft, that we necessarily have the adequate site development for implant later on. In fact, quite often, a secondary sinus lift bone grafting or augmentation will be necessary to provide the adequate bone height for the implants. So this was one of the important observations in this type of anatomy. Now, so the site graft is one way, the three-layer site graft is one way to address this. The second way is an alternative technique that I refer to as a PRF plug. PRF, platelet-rich fibrin, essentially a technique where we draw blood from the patient and we can concentrate it into the platelet-rich component and create a fibrin plug. And this is kind of what it looks like. And so in this case, we can kind of see how there's an extraction of an upper third molar with a small amount of sinus perforation. And all we do, instead of the bone graft, we essentially place the platelet-rich fibrin, which comes into a kind of a membrane, fold it, place it, and just basically one suture just to approximate the soft tissue. And this is another way to provide some sort of an occlusive material, a natural biological dressing in that sense, to minimize the complication from the sinus perforation. And in fact, of course, you know, from a biological benefits of PRF, when we look at the platelets, with a number of growth factors that it has, it provides the biological environment for enhanced healing and the proliferation and cellular maturation, and also its regenerative benefits. The PRF clot contains a high number of platelets, and of course the number of different growth factors that is very biologically advantageous to use. Now, just to quickly go over the three types of platelet-rich preparations that are available. Of course, initially the PRP or platelet-rich plasma, the PRF, which is the case that we just shared, platelet-rich fibrin, or using the platelet-derived growth factor. And each one of them have a different property in terms of preparation and ease of sort of creating during the procedure, but for the most part to have similar characteristics in terms of their biological potentials in inducing the healing process and really acting as a occlusive dressing in there. And so here's a case that, again, to show the upper impacted third molar, which was extracted traumatically, and right away we can kind of see that there is a sinus floor and a perforation. And we'll go ahead and prepare, in this case was a PDGF, platelet-derived growth factor, where allows us to create a gel with a concentrate, which is quite easy to manipulate. This is placed into the extraction site. A second component of it, which is comes as a more elastic, harder sort of material, can be used as an occlusive right over it, and then primarily close the tissue over it. And this is the fashion that it's done. In terms of post-operative precautions, there are a few important instructions that need to be discussed with the patient when the sinus perforation has been observed, and whether it's grafted or whether we use the PRF. The first is basically recommending them to avoid nose blowing for 10 to 14 days to really avoid buildup of any type of pressure in the sinus, which could potentially essentially cause movement of air from the sinus through the perforation and into the extraction socket. We want to be as gentle as possible there. There are some circumstances where the patient may notice some bleeding from the nose area, especially if the perforation is much larger and if there is bleeding into the sinus area. And typically this subsides gradually in 24 to 48 hours. It's important to inform the patient so they know to expect it, and usually, again, it subsides. Sinus decongestants can be used certainly in larger perforations, or if there is some existing sinus pathology. In terms of antibiotic prophylaxis, using either amoxicillin or augmentin for 5 to 7 days is a good measure. Certainly, smoking can be a huge risk factor in terms of healing of any site, but particularly in sinus pathology. So it is highly recommended to speak to patients who smoke and make them aware of the potential complications associated with that. And in terms of the overall healing, really close monitoring for the first 2 to 4 weeks, just to make sure that the soft tissue is maturing properly and we're getting the proper closure over the ridge. The cases where we have a site graft, again, typically about 4 months later, it can be reassessed for the implant phase, and to see whether or not additional bone graft may be necessary, or perhaps enough bone has been developed to place the implant at that point. So if we kind of really put our total thoughts together in terms of how to manage extraction sites with sinus perforation, just to review, first, I think it's important to recommend and have a pre-extraction cone beam CT scan, again, to help us diagnose, to help us plan for the perforation, to help us have a frank discussion with the patient and prepare them for this experience, and not have situations where we have a surprise finding of the perforation, and all of a sudden the need to manage it with grafting. And of course, that'll be much better for the management strategy with the patient. Second, to adopt either the site bone graft or the platelet-rich fibrin therapy as an occlusive management to both minimize the chance of development of oral anterior fistula and also provide a better healing for future and really achieve bone and soft tissue closure that we intend. We also talked about the fact that the site graft has questionable site preservation benefits, really mainly in situations where we have this scalloping silhouette of the sinus floor around the roots of the posterior teeth, so this really helps us to prepare the patient, to advise them early on beforehand that the first bone graft is designed to restore perhaps the alveolar crest or the ridge architecture and also address the perforation. However, for the future purpose, if we were going to move through implant replacement therapy, that a secondary bone grafting is most likely necessary. So that way they're also prepared for that at a later time. Again, the degree of site preservation that we can achieve in this type of situations is perhaps multifactorial: patient physiology and healing, the sinus anatomy, what type of bone type, and these all can really affect the amount of bone that we can create over time. Again, thank you very much for joining us. We look forward to seeing you again soon at our future narrowcasts and also our future educational events. Thank you so much.